To wrap up this morning's session, it is my extreme pleasure, and I'm delighted to be introducing Dr. Mohammed Zaman as our final speaker. So Dr. Zaman is the Howard Hughes Medical Institute Professor of Biomedical Engineering, as well as the Director of the Center for Forced Displacement at Boston University. So his research interests are broad. His work is divided between cancer research and antimicrobial issues, and on the latter end, particularly looking into how poor quality medicines drive antimicrobial resistance in resource-limited communities or environments, and in developing models and solutions to improving access to quality care for resistant infections in low-income settings. So his contributions in these areas have been widely recognized and include a recent Guggenheim Fellowship for his work on antibiotic resistance in refugee camps. So beyond his academic publications, he has also written several books on the topic, including a 2020 publication titled The Biography of Resistance. So today he'll be telling us about some of his work into the drivers of antimicrobial resistance in highly resource-limited settings. So I will turn the floor over to him.
Thank you so much for giving me the opportunity to be here. I'm really honored and delighted to be speaking to all of you today on topics that sort of came in different presentations earlier today about sort of equity, about access, about financing. And I want to sort of take a slightly different perspective and look at both the challenges and the drivers of antimicrobial resistance in sort of places of tremendous complexity, in refugee camps and urban informal settlements, which are typically called urban slums. And what I want to talk about specifically are issues associated with the environment and drug quality, two things that are often not on the radar. But before I start, I want to sort of talk about something I learned this morning. I was told by a wise person that you can either give a perfect talk or you can wear a tie. So I wore a tie. So I grew up in Pakistan, in Islamabad, in early 1980s, and camps like these were not far from my home. So this is an Afghan refugee camp, and if you just pay attention to it, you see a number of things that are extremely disturbing. There's no privacy, there's no structure, there is no organization. And one would hope that these are relics of a disturbing past, but the reality is that they are not. They're present in many parts of the world in different forms and shapes even to this day. But when we think of refugees or displaced communities, we often have a monochromatic lens. If I were to ask you, tell me what a refugee or who a refugee is, there are certain things that we think of which may or may not be accurate. We often think of refugees who are leaving homes and going to another place, but not necessarily people who are displaced from their own homes in their home country. The case in point is in Yemen, or even in Ukraine, a significant number of people are not crossing the border. There are people who are displaced because the state chooses not to recognize them and consider them stateless. Bengalis in Pakistan, Rohingyas in Myanmar. When we think of number, we think of these people who are displaced last year, but we often don't think of Palestinians who were displaced in 1945 or 1947, right? So there are people who have been displaced for 75 years. We think of them as refugees, but that's an identity you and I give them. That is not their identity. Imagine somebody telling you who you are rather than you sort of having an identity on your own. Refugee is not an identity, right? So we often think of refugees living in refugee camps. In fact, 2/3 of people who are displaced live in urban informal settlements. They are permanently integrated in urban poverty. They do not live in camps. They do not want to be in camps for a variety of reasons. There are colonial reasons for that. There are reasons because there's nothing to do in camps. Nobody wants to be under a microscope. There are no job opportunities, all sorts of things. There is a relationship with the state that is often much more complicated. They are not just receiving aid and support and healthcare from the state, they're also actually contributing tremendously to the economy, both in the formal and the informal sectors. In Lebanon today, if you were to take the Syrians away, the agricultural system would collapse. Same thing is true in many other parts of the place. And many people have transient realities. They might be refugee for some time and stable and then refugees again. They may go back and forth. And all of these things are important to recognize as we want to think about what kind of health challenges do these people face, what kind of environments are around them, and how do we think about infection, about disease, and certainly about antimicrobial resistance. The challenge in Ukraine is the most recent one in a long series of challenges. And this is not even a year old, right? So we are looking at from the beginning of February, from the late February of this year, and there are about 7 million people who are displaced. The number of people who actually left home is about 14 million, about 6.5 have gone back, and we don't know what condition. But there's 7 million people all across Europe, some in US, some in Canada, and elsewhere as well, who are displaced from their homes. And this number is of September 22nd, so it's still increasing. And with sort of the recent rise in conflict, the number is likely to increase further. Then there are about 6.5 or 6.2 million people who are displaced within Ukraine as well, who have lost homes. There are a number of people who are unable to leave, either because they are men of a fighting age, so they cannot leave. They could be people who are socioeconomically disadvantaged. They could be the elderly. They could be people who may have mobility disabilities, all kinds of reasons. And there's tremendous impact on that. And this is just Ukraine. So if you dial back time to about a year ago, the challenges in Afghanistan, and keep going back year after year, and you'll see new challenges. The tragedy, of course, is that you'd be hard-pressed to see a report on Afghanistan today. Even though the reason it's Ukraine is multifaceted. Some of it has to do with sort of our preference for European stories. Some of it has to do with the newness of the story. And the reason we forget about Afghanistan is not because there's another crisis that is far more acute. It just happens to be new. The problem in Afghanistan has not gotten better. In fact, it's worse today than it was perhaps a year ago. And of course, when you look at this is a qualitative survey that just came out and was published recently in the Globe and Mail, is the fact that medical assistance, healthcare are important challenges that are facing these communities. And this is just in Ukraine. If you sort of look at some of the other parts of the world, this is going to be perhaps even more prominent there. We know from history that places where there are informal settlements, where there are refugee camps, are also places where you have repeated outbreaks of some of the pretty terrible infectious diseases. There is not a lot of data on the burden of AMR except some pockets, and there are several reasons for that. One, surveillance is often not on the radar of a lot of people. Two, there are ethical challenges in working in these places. It's not easy to go and sample. And then I want to go back to the question that Dr. Kumar asked earlier. You do all of this work, and then what? You've found that there are a whole bunch of people who have antimicrobial resistance. What do you tell them? That, well, you have drug-resistant TB, and you can't go to Germany, so I don't know what to say. Right? So there are ethical challenges in how you completely close the loop. And so surveillance is actually not that straightforward. Of course, there are lack of resources and all of that, but there are ethical reasons as well. This is a number earlier, from earlier this year, about 104 million people have been displaced from their homes. Think about the population of Canada and think about sort of the population of Norway or other places. This is about between a third and a fourth, about 30%, 28 to 30% of the entire population of the United States. These are people who are displaced not just by conflict, but also persecution. The climate change numbers are small, but what this does not include is actually economic collapse. So people from Venezuela who are leaving homes because their state has collapsed would often not be included in these kinds of numbers. So this number often tends to be an underestimate. This is Pakistan. I grew up in Pakistan. On the right-hand side and on the left-hand side, you see water where there were homes. This road was at a significant elevation. And you see this all over the country. A third of the country was underwater not too long ago. And so you're really seeing displacement that is a result of the confluence of climate change, conflict, and persecution. And of course, one would imagine that there are many, many challenges that are there that are going to be facing these communities. Again, as we note, people who are most often most vulnerable are the ones who are socioeconomically disadvantaged, who are people who are not the right ethnicity, or not the right religion, or not the right sexual orientation. You have sort of a whole list of communities that are often most vulnerable, and you would see that this is often associated with people who are discriminated against in general. When we think of drivers of antimicrobial resistance in these communities, and I'm going to sort of focus in the next part on sort of the mechanistic studies and sort of the more biology side of things, of course, there are reasons of prescription and consumption practices. You're also looking at places where there's a high population density, access to medicine, but there are two other drivers that, and I don't want to talk about those three, not because they're not important, but they're often in various discussions. I want to talk about the last two, the issue of drug quality and the issue of environmental impact. And the reason I want to talk about those is because there's an element of equity in both of these, and others as well, but here there is an element of equity. You might be taking the drugs as the doctor prescribes. You might be paying full amount for that, but the system fails and provides you with a poor quality medicine, right? So there is this absolute injustice associated with that. Or you're forced to live in a place that is an absolute devastating place in terms of environmental catastrophe and things like that. So I want to bring that part and see how we can think about those from a laboratory perspective and think about the mechanisms. I want to recognize the people who have done the work. Dr. Zohar Weinstein was an MD PhD student. I'll talk about some of her work. And Dr. Carly Ching did her undergraduate actually from here, and then did PhD in Boston, is now a postdoc in my lab. So when you're looking at drug quality, you're also looking at not just poor quality medicines, but also the destruction of the infrastructure. So this is a picture from Syria. You have the central medical stores that would sort of really be often impacted, and that allows for all kinds of drugs to enter the system, or if you had a mechanism to store drugs properly, that is often destroyed. You also have issues associated with poor quality manufacturing. You see top left, drugs that may be expired. I took a picture of that in March 2014. Expiration date October 2013. You have intentional falsification at the bottom left, and you have sort of lack of regulatory capacity on the bottom right. And you have a whole bunch of reasons for that. If you look at sort of the global numbers, anywhere from 10 to 30% of drug sales worldwide might be poor quality and substandard. Of course, antibiotics would be at the very top of that list, along with antimalarials. From a financial perspective, this is a huge loss to the system, but also the fact that this leads to drug resistance. And I want to talk about that. We assume that poor quality medicines lead to drug resistance. It's a good assumption, but the basic mechanistic studies on how that causes is often not known, right? You say, oh, poor quality medicine, oh, drug resistance. But we were very surprised that there were very few actual studies that demonstrated what happens at the genetic or the subcellular level. And I want to sort of focus on that a little bit. This is a shop which was very widely used in northern Uganda, very close to the South Sudanese border when I was there. And you'd see sort of all kinds of medicines very prominently. And they had no problem saying that they don't know where they come from, that they are not stored properly. And they would sort of look at a patient and say, well, I think you have malaria, you should get this. I think you have fever, you should get this. And it's very easy to dismiss that and make fun of these people. But you have to realize that this is all they have, right? So the pharmacist in these places plays a central and a pivotal role as being your primary care, as your pharmacist, as your counselor. And oftentimes, because there is no antimicrobial susceptibility test in these places, the antibiotic that you get is not necessarily what you need. It's what they have. So you really have to think about sort of what exactly are the challenges in these communities. So the question I want to ask first, and I'm a big fan of doing very simple experiments trying to understand what might be going on. So what you'll see here are not sort of very high-end experiments, but sort of simple questions and trying to answer them in a simple way. So substandard medicines and fake or falsified medicines typically fall into two categories. Substandards are the ones that are not outright fake, but would have amount of active pharmaceutical ingredient terms that have been used before at a higher or a lower level than what is what is printed on the packet. And falsified products are products that are deliberately or fraudulently misrepresent their identity. Remember that globally, the consumption of things such as fluoroquinolones are increasing. And the 3 places that I mentioned at the bottom, the top left is where I live in Massachusetts. It's about a 20-year data, and the number has remained more or less constant per capita over some number. If you look at Lebanon, a place with a high number of refugees, the number has increased about 3-fold in the same period. In Jordan, again, about 3-fold, somewhere in that region, and in Pakistan, more than 3-fold over the same period. And this is just for overcrowded loans, right? And then you also have quality issues, so just imagine sort of the impact of that as well. So how do substandard antibiotics lead to antimicrobial resistance? We know that they are ineffective because they impose selective pressure. What that means is that a good quality antibiotic would clear the population over a certain duration, certain time, and a substandard antibiotic would lead to some kind of resistance over a period of time, and then that population will eventually start to dominate. Going back to Christine's point that it is not the person who's becoming resistant, it's the pathogen, or it's the bug. I learned last night that pathogen is not a good word. I shouldn't use it, so the bacteria, because pathogen apparently, I have to figure it out, anyway. So the question is, what is the magnitude of this change, and can we detect it? And if we don't detect it, how do we sort of really prepare ourselves for that? So drugs can be substandard because there's a high or a low amount of active pharmaceutical ingredient, excipients, things that are in there that are not active pharmaceutical ingredients, and also, of course, the presence of impurities. So what we're going to do in this case is we're going to sort of do a very simple experiment. We're going to take Cipro, we're going to take E. coli, and just vary the concentration and see what happens. And the experiment is, again, simple. What I like to think about is that I want my undergraduates to be able to do the same experiments. And again, the grad students build on the complexity, but the experiment at the starting point should be able to be done by people who are coming in with no background or very little background. So you take media with Cipro, go from 0 to 110%. You put E. coli culture in there, and then you divide it in sort of various corresponding treatments, 10% and 20% and so on. And then you look at survival and measure resistance. And no surprises that initially, as you sort of look at the concentration of the drug, most of the population dies. That is not surprising. But it is sort of in the tail end which what we are most interested in, not necessarily in the early part of that. And if you zoom into the tail end, what you notice is that low-level increases in resistance develop after exposure to 20 to 30% MIC. So instead of full MIC, if you do 20 to 30%, you start to see things that are becoming resistant. Now, this is just a low concentration of the drug that we are looking at. So again, no surprises there. Exposure to MIC leads to low-level resistance. 10% MIC reduces all viable cells, 75% change. But the question is that the things that you're starting to see in resistance, how stable are those? Does that go from one generation to the other, and how stable that is? And when we did that, what we said, mutant strains, after multiple passages in drug-free medium, have now low-level resistance, and fold increase can go up to 4 or 5-fold over 24 or 48 hours, right? So now we are seeing that if you expose it to low levels, you would see that, and then become sort of stable as you're going from one passage to the other. But then we start asking, sort of, remember, these things are only exposed to Cipro. And what we are interested in are the changes that you start to see going to confer resistance upon you for other classes of drugs that have nothing to do with Cipro and have nothing to do with what you have been exposed to, right? So imagine a realistic scenario that you were getting poor quality Cipro and you get infected with something else. Does that drug also start to work ineffectively because you were exposed to poor quality Cipro? And there we were actually quite surprised. We looked at 3 different classes of drugs here and noticed that, again, fold change in MIC, even though we had not exposed the bugs to any of these drugs, right? So you can start to see that that kind of changes are going to start to impact broadly, even in a very simple lab culture. So what we sort of started to do a little bit more digging in, and what we noticed was that mutants displayed single mutations in gyrase A, AMR, ACRR. Some of those were clinically novel, some of them were well known. And this is a very simple experiment, exposing subtherapeutic ciprofloxacin to E. coli, right? We are not going to much more sophisticated systems as well. But what we do know is that this kind of weak resistance, 4 or 5-fold, would clinically be under the threshold. So the clinicians wouldn't be worried about it. But the argument here is that can that be a reservoir for subsequent larger resistance outbreaks that we are concerned about? So what we did was, we developed, we started looking at some of these issues that low-level multi-drug resistance may serve as a first step towards higher level of resistance, right? And again, this is a simple experiment looking just at Cipro. And what we noticed was that still, we're not seeing that at the clinical level. However, initial mutations that are acquired because of these are often seen in higher level resistance as well. So poor quality, simple experiments lead to resistances that are often associated with higher level resistances that are often seen in the clinic. So does that mean that every resistance that you would see in a low-income country in a hospital is because of poor quality drugs? No. But does that mean that none of it is because of poor quality medicines? That is also something we do not know. And that is something to think about as we move forward. And so from an epidemiological standpoint, again, as I said, surveillance data is often lacking. But what we do know is that when sort of migrants have been we have sampled things from migrants, anywhere from 20 to 25% of migrants have been seen to have significant sort of burden of drug-resistant sort of bacteria in them. And one of the projects we're working right now is sort of looking at migration and the microbiome and seeing some of those things there as well. So in the clinic, what we are seeing is something that are resistances that are driven by poor quality medicines, but also what the clinic sees. So one of the recommendations is in places like India and Pakistan and other places is to really see sort of some of these pathogens and in the hospital setting to be able to see what might be going on there. The second aspect, which is just as important and troubling, is the fact that you have degradation products or impurities. That comes because of poor manufacturing. Because of lack of regulatory oversight, people are making drugs that are not of the right quality, or they're impurities that come into the system. Again, a simple experiment to do there is using rifampicin or rifampin. So rifampin actually auto-oxidizes into a product that US Pharmacopoeia would say is an impurity, right? So high exposure to heat, poor storage, all of those. So this lends itself to a very simple experiment. You take rifampin, you take rifampicin quinone, and see what quinone does, which is a poor quality product generated through auto-oxidation versus a product that is sort of used. Again, we know that rifampicin is still used in TB patients as frontline drugs in other cases as well, particularly in Southeast Asia. So the experiments are, again, very simple. What we do is we expose rifampicin and rifampicin quinone to E. coli, and what we notice that even small amounts of rifampicin quinone would lead to rapid development of resistance in E. coli, much faster than it would be in rifampicin. We looked at in both mycobacteria, smegmatis, and in E. coli, again, the same behavior, that there is a rapid development of resistance even in small amounts of rifampicin quinone. We looked at sort of RPOB cluster. Again, this may or may not be familiar to many of you, but RPOB cluster is the cluster that you would have typical mutations in for resistance in these systems. And we saw, again, novel mutations because of the presence of rifampicin quinone there. Same thing with other systems as well. And the last part I want to sort of talk about in this one is that even small amounts of impurities, these are process impurities. So imagine that there's a pharmaceutical company that is really not making a high-quality product that is not tested appropriately. These impurities themselves have antibiotic-resistant sort of driving capabilities, right? So in this case, you are looking at sort of green and red, and what you notice is that the three main impurities, ciprofloxacin, HCl, fluoroquinolonic acid, and ethylene diamine analog, would all have properties. So if you're really not making good quality products, and we do know from our own surveillance, not of antimicrobial resistance, but surveillance of quality of drugs in and around refugee camps, that there are huge quality issues associated with it, as unfortunately is the case in many places where there's lack of regulatory oversight. And again, here we are seeing the same thing, that the API impurities can really drive resistance here as well. In the last 5 or 7 minutes, I want to talk about the other side, the places where many of these communities live. So we know very well where they live, and oftentimes those are places which have absolutely no systems of sanitation, of quality, and nobody should be forced to live in those places. Places like this. So these are pictures that were taken by our partners in field sites in Pakistan. This is where about 1 million people live. They're all ethnically Bengalis, stateless people who the state doesn't recognize. And until 6 months ago, they were even denied COVID vaccine because they're stateless. You need an ID card for a vaccine. If you don't exist, well, you don't get a vaccine. It was only once they realized that it actually puts everybody else's life in danger, they said, oh, might as well vaccinate these people as well. So it's sort of the dark irony of how public health often is viewed from a very selfish perspective rather than one that is based on human dignity. But these are the places, right? I mean, so you can imagine the kinds of challenges that you were saying. We haven't done significant environmental sampling here, but I think one can imagine that it will be serious issues there. But also, the weapons of war create challenges associated with development of new drug resistance. So there are people here who have worked on Acinetobacter baumannii, which I'll come to in a second, and has been sort of associated with sort of development of new weapons and use of heavy metals in those weapons that stay in the environment and generate resistance as well. So what we start to see in some of these places, including in Pakistan, is that one of the most significant drug-resistant outbreak for XDR TB happened in these urban slums in Hyderabad. And you would imagine many other challenges that it was driven through sort of horizontal gene transfer. You already had drug-resistant typhoid, and then of course you get a plasmid from E. coli in that terrible environment, and then you start to sort of develop very complex situations. So what we want to do, and this touches on one of the issues that Kevin said, is to be able to start to build some of these models, some of these mathematical models that allow us to bring many of these things together. The fact that what kind of environment you're in, the fact that you have sewage issues, the presence of metals and other things as well. And again, the model is relatively straightforward, and I'll be happy to talk about that in more detail. We can look at horizontal gene transfer as well as chromosomal mutations and see sort of the relative balance between the two as well as the relative rates and see what happens in a sewage-like environment. This would not mean much if we were not able to do experimental studies, so I'm very fortunate to work with a brilliant colleague, Professor Ahmed Khalil, who has come up with a system called Evolver, which is a fully self-contained system that allows you to change your media, your temperature, different antibiotics, different pathogens, and to be able to see sort of the growth of resistant pathogens as a function of time. So what we can do is we can simulate the sewage-like environments by changing sort of organic matter and presence of different antibiotics or different sort of pathogens and see how that changes as a function of time. The mathematical model, I'm happy to explain in more detail, but these are coming largely from ordinary differential equations. So they're basically rate equations of how something changes as a function of time. We can also look at things in combination. Just showing results that, in general, we do quite well in terms of the Evolver studies and the studies in the mathematical model. We can see how different antibiotics work together. We can also see how the rates increase or decrease. Remember that oftentimes people would say, well, have you sampled from the place? We do, but sampling is one time point. You cannot sort of see how something evolves as a function of time. You can do it geographically, you can do it in different seasons, but you cannot see the dynamics of the bacterial growth in the sample. As you can take that sample and sort of put it in the lab and then see that. But to do that from the field often doesn't give you the insights about the mechanism that you may be interested in. And we can look at interactions as well. I won't go into the detail of that. Coming back to this issue of environment, conflict, of course, takes a multidimensional toll on the health system. Your hospitals are destroyed. Doctors and nurses are, in some cases, killed. In many cases, they leave the system. But then there's the other factor that weapons of war, these large bombs, would have many metals that would become indigenous to the environment. And those metals, zinc and other heavy metals, actually promote. We have known this in the mid-1990s, that heavy metals promote sort of mutations, and heavy metals promote various kinds of resistance pathogens, particularly in Acinetobacter. to the point that in early 2000s, during the second Gulf War, the US servicemen and women started getting really sick. And because the Congress couldn't pronounce the name, they called it the Iraqi Bacter. And that was, I mean, sort of there were congressional hearings to figure out what was going on. We don't have a smoking gun to say that, oh, this weapon or this metal does that. But we do know that there is a tremendous sort of correlation. We don't know the causation yet, but correlation between active conflict and development of antimicrobial resistance for a variety of reasons. We've seen that in Afghanistan. There's good reason to expect that in Ukraine as well, right? So you have these conflicts, you have these heavy metals, and they sort of really impact it in multiple dimensions. We've sort of thought about that with our colleagues in Lebanon, in the UK, and sort of really thinking about what exactly happens there. And in our own lab, we've started looking at the role of zinc and what it does. So looking at a single metal, trying to reduce it to a single metal level and seeing that. And what we notice is that pre-exposure to zinc, so if you have zinc in the environment, and only at 5 days, leads to enhanced development of resistance. We're now doing it with cadmium and copper and other things as well, trying to sort of deconstruct the problem and then really building it again as well to see, and again focusing on Cipro and other drugs. Taking a point that Kevin raised, this issue of ecology and environment. I hadn't seen Kevin's slides, but I think because we were on the same flight, I think there was some sort of kind of telepathic movement in that little plane of thinking on this. But we have to think of these places as complex ecologies. We cannot sort of think of people out of their environment or environment out of the people. As I said, some of the people have been in camps in Shatila in the middle of Beirut for 75 years, right? So the ecologies constantly change. So how do we think about that in the context of AMR for people who have no political, financial, social agency? And this brings me to absolutely shameless self-promotion. The new center that I am directing aims to bring these kinds of conversations on a broader issue of refugee and statelessness and sort of internally displaced communities' well-being. Because historically, these questions have been looked at from the context of political science, or in some cases, sociology and economics, but issues of important, urgent global health relevance are often not asked in these contexts. And the goal is to bring everybody on a single platform and really think about sort of ethical approaches, solutions, ideas, and think of not in a single region or a single place, but really something that cuts across. I'll be happy to talk about this as well. So I want to end with two things. So what are the next set of challenges and looking into the future that we think are important when we think of AMR? First is the tools that are fit for the purpose of discovery, analysis, and impact. You really need to understand the local context in these places to be able to understand what might be going on. The social context, the political context, the economic context, the environmental context, thinking of One Health issues. I didn't even talk about the veterinary aspect, but that's also important. Urban environments, not just in camps. So urban environments are increasingly the places where a lot of the forced migrants would be forced to move. And what exactly is the situation there? Urban informal settlements. Oftentimes, when we think of refugee integration, we are basically integrating them into local urban poverty. We are really not integrating them into society properly. And of course, this nexus of climate change, conflict, and the migration that could be driven by one or the other, and sometimes together, or you are driven by one and you face the other, and what impact does it have in the context of health? You know, right before COVID, I was in northern Uganda, as I mentioned, very close to South Sudan, and this was the outside of a health clinic. And I felt terrible, right? I mean, the idea of a barbed wire means you are pushed out rather than sort of welcoming in if you're sick. And that really disturbed me. So I thought about it, and I was sort of reading something, another professor at Boston University who was no longer with us, and his words really spoke to me that the opposite of love is not hate, it's actually indifference. And for far too long, we have been sort of these people have been invisible to us, or we've been indifferent to the challenges that they face on a day-to-day basis. And I want us to really collectively and individually think about the challenges and not being indifferent to that. So with that, I'll thank the people who actually do the work, and I take the credit. Undergraduates, the people in the staff, and as well as sort of our funding sources. Thank you very much.